All right, so welcome everyone, and thanks for joining us today. Before we get started, just a few quick housekeeping notes. Today's session is being recorded. The recording will be posted to our YouTube channel and shared with you afterwards. You've been muted on entry to help reduce background noise. Please keep yourself muted unless you're speaking. You'll have an opportunity to ask questions at any time using the chat function. And there will be time for our presenters to answer these questions at the end of the presentation, along with any live questions that might come to you at that time. We'll also be using polls, so your participation is encouraged for that. And we'll also have an evaluation for you to fill out at the end. We'll have that QR code up at the end and link in the chat. So we encourage you to fill that out so we can improve events like these in the future. And with that, we can get started, beginning with our land acknowledgement. So we acknowledge that the Regional Geriatric Program of Toronto operates on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, the Chippewa, and the Wendat peoples. This land is covered by Treaty 13 with the Mississaugas of the Credit and remains home to many diverse First Nations, Inuit, and Métis communities. We invite everyone joining us today to take a moment to reflect on the traditional territory you are on and the histories and contributions of Indigenous peoples who have cared for these lands. As we acknowledge the land, we also recognize our shared responsibility in advancing truth, reconciliation, and meaningful action. The RGP of Toronto is committed to supporting improved health, wellness, and self-determination for Indigenous people. As we learn together today, we encourage you to reflect on how our collective work can contribute to better experiences and outcomes for older Indigenous adults. Next slide. So as people with IDD live longer, many are experiencing the same age-related conditions as other older adults, but often with the additional complexities related to communication, assessments, transitions of care, and access to appropriate supports. So today you are viewing part one of our webinar series that was developed to help strengthen our collective understanding and confidence in providing compassionate, equitable, and evidence-informed care for this population. Today's session is an opportunity for us to learn from experts in the field and to reflect on how we can play a meaningful role in improving health outcomes and experiences for older adults with IDD and their care partners. So with that, it's my pleasure to introduce our first speaker, Dr. William F. Sullivan. Dr. Sullivan is a practicing family physician and holds a PhD in philosophy. Since 2023, he has served as the Joseph P. Kennedy Senior Chair in Bioethics at the Kennedy Institute of Ethics at Georgetown University. He is also a full professor in the Department of Family Medicine at MedStar Georgetown University Hospital and teaches as affiliated faculty in the Department of Philosophy at Georgetown University. Dr. Sullivan's clinical and research work focuses on improving health, well-being, and flourishing of adults with intellectual and developmental disabilities. His contributions include promoting decision-making capabilities of people with IDD in healthcare and leading the development of the primary care for adults with IDD Canadian consensus guidelines. He's currently collaborating with international partners, including people with lived experience and their families, to update these guidelines and adapt them for low and middle income countries. We're very, very grateful to have him with us today. And presenting with him is Angela Gonzales. Angie is a nurse professional practice lead and clinical nurse specialist at Surrey Place, and she also holds an adjunct appointment with the University of Toronto's Lawrence Bloomberg Faculty of Nursing. She is part of the ECHO Ontario Adult IDD program, and her clinical work includes providing nursing consultation through Surrey's Place's Plus 45 clinic, where she supports adults with IDD who are navigating later life stages. Angie brings the expertise in aging, complex care, and personal-centered approaches for adults with IDD, and we're very fortunate to have her today with us as well. So with that, I will pass it along to our presenters.
Great. Thank you very much. It's a real delight to be here and to be presenting with my long-term colleague, Angela Gonzales. Can you see and hear me okay? Great. So, the topic that we were asked to present on is something rather general as an approach to caring for adults with intellectual disabilities who are aging. And the title is Love in Clinical and Ethical Deciding, and how promoting relational care and flourishing uh, in older people with IDD um, can help with care. Just to declare that we have no conflicts of interest, and that's our contact information. So we have a couple polls to start with, and this is the first one. And so the question is, have I engaged with an adult with intellectual and developmental disabilities in my practice? And we just want to get a sense of the audience and where people are at. So many people have engaged. Um, so that's great. And nobody said uncertain. So, so that's great. So the next question I'll ask is, uh, oops, let me go back now. Um, so have you had some training regarding health or other issues regarding adults with intellectual and developmental disabilities? So here it's a little bit more split. Um, So I think part of my message, or our message today, will be that there's a very good fit between expertise in caring for older people and then just adding that the person also has an intellectual disability. And so I hope that by the end of this, people will feel like they do have the skills and important things to bring to the care of adults with intellectual and developmental disabilities. So, this is our agenda. We're going to start with a story. It's Sarah's story of a woman with an intellectual disability, and then talk about these other parts of the agenda. So I'll maybe just invite Angela. First, I'll just kind of flag some of our key learning points. So I think the point of this presentation is that people with intellectual disabilities are living longer and they can flourish in this later stage of life, uh, especially if provided with the conditions for such flourishing, which I'll be talking about. And that healthcare professionals can support this importantly by attending to distinctive features of aging uh, among people with intellectual disabilities. And clinical deciding regarding intervention options or treatments involve ethical deciding. That people with IDD should participate meaningfully in deciding, and that this deciding involves a method, which is something we'll be talking about. That this method is relational, and in this method, love plays a fundamental and key role. So I'll turn it now over to Angela.
Thank you so much. So I'm going to introduce a case study, and it's Sarah. It's about Sarah. Sarah is a 55-year-old single woman. She has a history of living in an institution until 2006. She now lives with an older brother and his wife, her sister-in-law. Her diagnoses include intellectual developmental disability in the moderate range, and it's related to Williams syndrome. She has spoken language, so she communicates with words. She is affable, very sociable, and she attends a day program 3 times a week. That's very important to her for meaningful activity. She also loves going to church, and she's a choir member. Unfortunately, she experienced the loss of her best friend, Laura, who she loved attending choir with, and Laura died 8 months ago. She also is experiencing or living with visual and hearing impairments. She has type 2 diabetes and hypertension. Her body mass index is above the normal range. It's 35. So she's in the what would be called obesity range. And she has chronic constipation as well. Her medications include metformin and semaglutide for the diabetes, terzocin for her heart, and magnesium oxide supplements. The last primary care office visit was 9 months ago, and now her current situation involves she has increased difficulty with hearing. She's had at least 3 falls in the past 3 weeks, no injuries, no apparent injuries. And other life experiences include she's having trouble with familiar activities of daily living. She also has lost interest in attending activities that she previously loved doing, like the church and her choir. And now there are some new responsive behaviors or physically responsive behaviors and oppositional. So oppositional or what could be labeled as aggressive behaviors. There are now disruptions as well. She's presenting with difficulties in getting through the day program and is having disruptive type behaviors there. So now there's also caregiver fatigue in the home, at home. Now passing back to the poll. So, oh, I'm seeing that the poll is being answered. That's great. Alrighty. So Sarah's family doctor thinks Sarah's recent changes in behavior are signs of aging. Do you agree? We're seeing a mixed response. Yeses and more no's. No. Okay. Some uncertain about the changes in behavior being signs of aging. And there was another poll, the second poll, question number 2. So we're seeing, so far, I think I'm still seeing question 1, but I hope you guys have gone ahead and seen question number 2. So the second question, I didn't see the pop-up yet, but the second question is, the family physician decides to refer her to you for assessment. Would you accept this referral? Oh, thanks, Ashley. You could see it. Okay, so maybe it's been answered then. Thank you. I'll pass it back
Let
to
me
you.
just reopen it again. Sorry, it looked like it closed
Okay.
very quickly, but we got a few
Okay.
responses. Okay, I've
Oh,
restarted
thank
it.
you. Okay, I'm seeing it now.
There we go.
Yeah, so we're seeing 100%. Okay, now it's changing. It was yeses. Again, we have mixed yes, no, more information needed. Great. Okay, thank you. I'll pass it back to you, Bill.
Great. Thank you very much, Angela, for that. So, I guess I'm going to talk now about this question of just aging with intellectual and developmental disabilities. And I would say that this part is kind of, what's different about people with intellectual disabilities who are aging. And the first point I just wanted to make is that it's very hard to make a general statement that this group is very heterogeneous. So there's a range of intellectual and adaptive functioning levels. Um, it was mentioned that Sarah is in the moderate range of disability, but it can go from a severe to profound to mild ranges, all of which have different meanings. different ways of communicating. Sarah communicates verbally, but often or sometimes people communicate in other ways. And one of the points we'll be making is even through body language or behavior. The other thing about Sarah's case is that she has a syndrome called Williams syndrome. And this is not known all the time, maybe half the time. One might know what the etiology is, but each syndrome can have very specific physical and behavioral phenotypes. And then another part of this heterogeneity is that life is dynamic and complex. And so needs will vary and change, as will supports, including for deciding. And so we can talk about capabilities, vulnerabilities, and especially for this talk, the importance of relationships in providing such supports. So another point is that, one of the responses to the polls was that someone like Sarah, because of her chronological age, would not meet the criteria for geriatric services. And the kind of the issue here is that the onset of aging signs and symptoms are known to begin earlier among people with intellectual disabilities. And so this idea of the need to access the expertise that folks in this meeting have might be restricted. And even there might be this feeling that one needs expertise both in issues related to people who are aging, but also in intellectual and developmental disabilities. And that such expertise is probably fairly rare. The importance of establishing baselines early to detect such changes. And so we saw in Sarah's case some change in her typical functioning with activities of daily living. And is this change significant, and is there a baseline to compare it to? Another point is that many of the assessments for issues related to aging might need to be adapted to be specific for people with intellectual and developmental disabilities. And at the end, we'll be sharing links to some resources that do that very thing. So the typical assessment of dementia needs to be adapted. We listed a number of medications, and I know that this is a real strength of kind of a geriatric approach to kind of audit those medications and see which ones might be contributing to symptoms. And in that list, there were several that were, I'm sure many of you recognize, would be potentially problematic. Another would be kind of the importance of thinking about end of life earlier and adopting a palliative care approach that may need to be also adapted for people like Sarah. And then finally, this idea of integrated supports that involve these range of issues, which we'll talk about more, but a very specific one is decision making, which is often, I think, not attended to. So we talked about kind of the heterogeneity of the group, the earlier onset of signs and symptoms, and there's this other issue that I just wanted to flag, which has to do with diagnostic overshadowing. And what that means is that sometimes the fact that a person like Sarah has an intellectual disability stops the questioning of why these changes, so that it's attributed, many things that are actually new diagnoses can simply be attributed mistakenly to the fact that she has an intellectual disability, or that this is normal aging in someone with an intellectual disability. And this is, I think, a big message. Communication can be verbal, but it can also be through behavior or body language, as was happening in Sarah's case, and to interpret that as expressions of distress, that this is behavior is communicating distress often, or a feeling of being unsafe or overwhelmed. And a point here is this notion that's very common of trauma among people with intellectual disabilities and how that might appear. And the point is not that Sarah is actually, we think she's safe, but does she feel safe as an important kind of consideration. And then consider an IDD adapted systematic and comprehensive approach to assessing things like changes of behavior. One of the resources that we will flag goes under the acronym of HELP, and it stands for the H is health, E is environment, L is lived experience, especially of trauma, and then you think of a psychiatric diagnosis. And so it's just kind of another method to work through these issues and not to forget that it might just be a health issue like a medication problem. So the last part of this that I wanted to mention is, love's in the title. What does it have to do with any of this? What I'm meaning by this is this notion of a kind of a commitment to the integral adapting and flourishing of people with IDD or other people. That's what is meant by this. And I wanted to say that this is affective. There's a feeling dimension that is more than a sense of duty. And it has a cognitive importance, which is more than being kind, empathetic, person-centered, or inclusive. Not to say that there's anything wrong with that, but what this is getting at is somehow not captured by any of those terms, and it promotes wise, clinical, ethical deciding. So the point is that all such deciding, though clinical or public health, is about doing something that's purported to be an improvement, to be promoting something that's worthwhile. That makes it ethical. So I'm going to shift now and just talk for a minute about this, this approach that I'm calling clinical ethical deciding with goals, with the R. And just to say that what I'm getting at here is this movement from a diagnosis, which I think folks in geriatric medicine are very good at, kind of getting the facts right, to then thinking about an intervention or an option. And that this involves ethical deciding, guided by values and intended concrete goods. It's not about anything abstract. That's why cases are so helpful. So people with IDD ought to be involved as much as possible as agents in such deciding, and to recognize that agency, especially with people with intellectual and developmental disabilities, ought to be thought of as relational. And so people are not isolated individuals, trying to independently make a decision. If that's possible, that's great. But often for people with intellectual disabilities, more support will be needed. And that such a way of deciding involves a method. And that a key role of healthcare providers is to be aware that there is a method. The proposal is we do this all the time spontaneously. This is just an effort to make it explicit so that we are more methodical in helping people and ourselves to think through issues. So this is what GOALS refers to. It's an acronym. The A refers to the agent, the person deciding, or the group deciding a policy. It's always regarding some concrete context. In this case, we were talking about Sarah and her context, which is actually complex and it's dynamic. It's been changing. We're talking about what can we do about that complex dynamic life system to improve it. So I'm calling this the good, but it's actually some improvement to life systems at time zero. So it's life systems prime. You could say you're nudging it forward with some intervention, and we call that an option. In the case of many clinical healthcare decisions, it would be a treatment or treatment plan. But in the case of public health, it's a policy that is regarding not just an individual, but a group. And finally, the R is that all of this takes place in the context of relationships, and that these relationships here are colored red for a reason that I'll get to in a minute. And so not all, it's just to flag that not all relationships are positive in this process. So here's another way of unpacking this. And I think that all this might sound a bit complex, but it's essentially just an elaboration of a biopsychosocial, perhaps spiritual model, adding two more elements to it. And it's a way of thinking about the complexity of my life and your life, anybody's life, the various things that are going on. So rather than say bio, psycho, I say vital. And what it has to do with is that, but also ecological relationships, all the things that involve the vital, which is life. And then we can talk about social. And again, everybody's familiar with this, but the key interpersonal relationships in which Sarah, for instance, is embedded. We can also talk about cultural societal. This is kind of a new category, but it has to do with the relationships and ways in which communities are organized. And for us, one of them is health and social services arrangements. And the impact of these organizational decisions for people with IDD, for instance, if there's a strict age criterion, that's a problem. If somebody with IDD is less than that age level, but experiencing significant geriatric issues. So this is a new one, I think, that, and it has to do with the fact that we decide as well. So through relationships through which the values of individuals and communities are learned, affirmed, and supported in deciding. So these are examples of those things that are part of our life systems and Sarah's. And then finally, kind of this ultimate aspect of the human person having to do with ultimate meaning and value, typically through spiritual and religious traditions. So this is basically, I would say, a little elaboration on the old biopsychosocial. And it's meant to be comprehensive, but it's also meant to be ordered. And one way of ordering is that the lower become conditions for the higher levels. And conversely, the higher levels influence and shape what's happening on lower levels. So I'm just going to relate what I've been talking about life systems to options and the good. So what life systems are in Sarah's case is concrete. That's what's going on in her life, positive, negative, missing, whatever, on each of these levels. And the question is, how can we best support her, preserve, prevent, restore, promote various elements of her present life systems to make them somewhat better, nudging them toward what you could call life systems prime, or at time two, which is another word for the good that's intended. And the first is what is actually the case to what ought to be. And then in this context, we think about our interventions, which are adaptations on these various levels to either preserve or promote some intended good. So what this is doing is holding together three things. What's not here is the agent who does this holding together. And we haven't yet flagged the relevance of relationships in all of this. But remember, there is these influences of these levels. So the whole point of relational care is that it is addressing fears and other vulnerabilities negatively shaping deciding among people with IDD. So part of that relationship involves moving from the fearing that may be motivating deciding to something else that has to do with kind of concrete steps to promote flourishing or protect things. So what does all of this have to do with Sarah's case is the big question. And I guess I'm wondering whether there's a chance for people to pipe up and see if you can see how Sarah's case illustrates things that this approach helps us to think about, perhaps in ways we would not have normally thought about it. So would anybody like to venture some thoughts on this? So I'll just suggest that one of the ways of thinking about goals, that it's written so that the word makes sense, but the process of thinking through these components is different than how it's spelled. So the one thing that is talked about to consider first is the agent. And in this case, decisions about healthcare are about Sarah. And the question is, how involved is or could she be in the deciding? And so one of the implications of this is that if you think of this, her deciding as essentially relational, and then who are the key people in her life who can support her deciding becomes a key issue. So it's sort of a bit of a shift from the typical let's assess cognitive functioning and decide whether the person's capable or not, to let's assess what adaptations are being done and what supports are being provided so the person can be involved as much as possible. So it does speak to the role of a healthcare provider, for instance, in helping to support this, and also by helping both Sarah and maybe it was Tom in her life, her brother, who would be involved in these decisions, to think about the issues in terms of the relationship between what's happening in her life that's complex and dynamic and a lot of recent losses and changes, and what would be something that would be desired. What can we do that would make things better so that life systems to good, and then thinking about options in connection with the two, not abstracted from them. There are other sort of things I think that we could talk about. That one of the issues in the case that I think we're many very familiar with the biopsychosocial and social determinants of health considerations, but what about the moral and what about the spiritual for somebody as part of their flourishing that can be supported? There's a cultural societal issue here about advocating for coordination of healthcare services, such as between developmental services and health, and particularly geriatric healthcare services, as she's transitioning into older age. And then finally, kind of to think about the importance of relationships in Sarah's life, and just to be aware of her capacity. She's lost an important friend recently, and so there's grief issues, but there's also the possibility for supporting new friendships. And then one also ought to think about the importance of caregivers, and the case noted caregiver stress or fatigue, but how important that is as some, people that are so important on that relational dimension to Sarah, and making sure that there is some care for such caregivers. So just in the interest of time, because I want to leave some room for discussion, I'll just review some of the points, the learning points that we were hoping to raise. So people with intellectual and developmental disability are living longer and can continue to flourish in later years. That healthcare professionals can support this flourishing by attending to distinctive features of aging in people with intellectual and developmental disabilities. And that clinical deciding regarding intervention options, treatments in the clinical setting, involve ethical deciding, and that people with IDD should participate meaningfully in deciding. And this deciding involves a method, which is what the acronym GOALS are, alerts us to. And then finally, this method is relational, and love plays a key role in it. That's more than merely affective, being kind. It's cognitive as well, and it helps to grasp and promote wise and caring decisions. So I'll maybe turn it back to Angela to kind of talk about some resources that will might be useful. And we will share this PowerPoint later, and there's these QR codes to obtain these resources. Angela?
Thank you so much. It is such a privilege to be in this space with you, Dr. Sullivan, and always learn from you. This is the rock that I cling to, many of us cling to in our developmental services. The DD Primary Care Program had many publications. This is an example of one of them that was published in the Canadian Family Physician Journal. But there are also lots of guidelines and tools on a DD Primary Care website. And so, yes, there are various levels of evidence in those guidelines and tools, and it is the Canadian consensus guidelines. So it's the only thing that we have really that we cling to for evidence and practice in developmental disabilities. There's also this resource that is from the Healthcare Access and Research and Developmental Disabilities, HCARD. Again, lots of research that's Ontario-based, and this is one of the projects from HCARD based on aging. There's lots of resources and tools on the HCARD website as well, but there was an aging project report that came out of HCARD. And this is the NTG EDSD, which stands for National Task Group on Intellectual Disabilities and Dementia Practices, the early detection screen for dementia. And I saw, I'm so happy I saw that Dr. Gina Ohm is part of this, is on this. Dr. Gina Ohm is in the geriatric psychiatry clinic at Surrey Place, the Plus 45 clinic. This is one of the tools that we use through our clinic, and many of the developmental service agencies are using this tool in order to capture baseline and progression from baseline. And it's not only about dementia, but it also highlights physical health issues that change from baseline. So it's quite a crucial tool for us as well. And the DD Primary Care website I mentioned earlier, this is taken from that website. It is one of the tools, and it is for advanced care planning. So with this tool, there is a form, a template that, for example, in our clinic, we also we facilitate filling out the advanced care planning, and developmental service agencies as well. We're promoting it with them to help in their relational care, in their relational closeness with a person who is supported through some of the developmental service sectors, they may be using this care plan, but it's also hopefully promoted through other healthcare providers who can facilitate using it. And the main access point for any funded developmental service for adults with intellectual or developmental disabilities is through the DSO, Developmental Services Ontario. There is a DSO Toronto region that is based at Surrey Place. And so there's the website for DSO Ontario, but we have different regions. There are 9 regions. One of them is Toronto. Again, it's based at Surrey Place. And that is basically the access point, similar to the Ontario Health at Home, the home care access point. You would go to Ontario Health at Home for any home care or community services. This is our access point for any funded developmental services, including clinical services. And I'm biased, so I'll mention the Plus 45 clinic that Dr. Gina Ohm is also associated with. It's based through Surrey Place. It offers consultation. There's geriatric psychiatry. There is social work, there behavior analysis, and nursing. And we're connecting as well to the clinical services at Surrey Place. So thank you very much.
Well, thank you so much, Dr. Sullivan, Angie. I really appreciate that presentation. It's really a great reminder, to have this sort of framework to help us with our approach. And again, as you mentioned, these are things that we should be considering anyway, but it's great to have a sort of a stepwise approach as a reminder to not overlook any of these things, because as you mentioned, it can have such an impact on outcomes and treatment. So thank you again. At this time, if there's any questions, please feel free to unmute yourself and ask a question, or ask it in the chat. And we can have Dr. Sullivan or AG answer that. Okay. We have a question from Ashley. Plus 45 clinic is only for those in Toronto? Question mark.
Really good question. And I see Gina, you're on camera now. Gina could also answer that. But yes, it is technically for the Toronto postal code, the M postal code. But we're looking at ways to reach out or work with others in Ontario, and we have. But in terms of clinical services, technically, specifically, it is for GTA.
So that's another kind of system issue, isn't it? That there are all these restrictions, all of which are decisions, right? So good to think about that is not carved out in stone.
We have a question from Rana. Rana, go ahead and unmute.
Hi, I'm Reina. Just some amazing points from both of you. Thank you very much. It's really interesting because I work in Geri-Onc at Princess Margaret, and we're part of UHN, so we can only really see we're limited to 65 plus. And I do all the triaging, and we're pretty much limited. Sometimes we'll see patients 60 and above. We never really go below that. So I was just wondering, what do you consider geriatrics for IDD patients? And then I guess the other thing is, where do we send them for services? Because all of us, like I'm the clinical nurse specialist there, and all of us work with the geriatricians across Mount Sinai, UHN, Toronto Rehab, and they won't see patients less than 65. So we end up sending them to the memory clinic, neurocognitive clinic. I guess, would we send them to you if they needed sort of geriatric issues? Like, what's your number that's considered geriatric in age?
Really good question. And so that's why we've called the clinic the Plus 45 clinic, because people are aging a lot earlier. So in the 40s, people might be presenting with frailty similar to, or 50s, someone is presenting with frailty similar to in their 80s. in general population. So again, life systems where it's unfortunate we face those barriers we can't access based on an age criteria that there isn't evidence for in this population. But yes, please refer. You're in Toronto with UHN. We would love to be in touch for sure. Please refer, yes. And if we can collaborate and work together, we would love that.
And it's on your sunny Surrey Place website?
Yes, it is. I can
Okay.
pop the link. Yes, I'll put the
Okay.
link as well.
Thank
Thank
you.
you so much for
Great
that.
presentation.
Thank you.
Yeah, Barb, go ahead.
Thanks very much for an excellent presentation on such an important topic that we all need to learn more about. Thinking about the services that you offer through Surrey Place, do they tend to be longitudinal, or like, I mean, much of the other parts of the healthcare system, you mentioned OH at home, it's very sort of episodic care. Can you just describe a little bit more about the services that people with IDD can access through Surrey Place?
Sure, and I'm happy to see Dasha Shortova is also on. She's the social worker, the transitional support services facilitator for Plus 45. Um, they are, they can be they are longitudinal, I should say, because Surrey Place's lifespan, it offers lifespan clinical services. But we have an open and closed type situation where we're involved. You could say short term, but not really. Sometimes people are involved for years. And if the goals are, we're no longer needed, then we deactivate or we close, but we can always reopen is the current situation. So in that way, we are long term, but at points when care and support and clinical services are needed. And so we're familiar with people for years. Like we have people who were lost in the healthcare system. And for example, I went in to visit someone else and saw the person in the nursing station area, the care station area, and got reconnected. And we were able to quickly reopen services. So I'm pretty proud of that sense in terms of the systems piece that the Dr. Sullivan is describing with Surrey Place. We have been quite flexible so far. Yeah. So thank you for asking about that.
So just one comment about this discussion. So I think what we're talking about is not Sarah, but a whole group of people across the province who are all going to be facing these issues as they age. And this then becomes a public health issue. And the one point I want to make is that goals that we illustrated using Sarah is in a clinical context of the one. But the same approach can be used for the many. And the intervention for the many is a policy. And the policy is based on some assessment of these life systems and these barriers and other things, and how that could be improved. What would be better? What might make it be a good? And that's a kind of a view of the common good that would inform policy decisions, also using goals, also with the view to providing the conditions for people to adapt during this transition and flourish as much as possible. So we didn't have time to talk about that, but the same method is proposed to work in both contexts. And I think a lot of the questions are about, I would say, the public health questions about policies, barriers, etc. But that's also, I think, important that it's not a whole new approach, that it's the same approach that is adapted.
Richard Sullivan, I actually had one question, and forgive me if you ended up addressing this, but you teased that red relationship zone in the goals diagram, and I was just wondering how, especially if there's some bad relationships or bad actors at play, how do you balance that with the person's autonomy and agency?
Right. So yeah, so that's a good point. The color red. what it is meant to signify is the most positive relationship that is not based on fear, but is based on this commitment to the integral adapting and flourishing as much as possible at this phase of life, even if somebody's dying, as possible, and finding ways to do that. And typically, this is going to be a family caregiver. And that's why it's so important that we include those people, but also support them in this difficult role. And then you could say that, to say that this is important is also to acknowledge that if it's absent or if it's actually negative, it's also important. And so it's just a way of kind of acknowledging how we are all relational, and that this is actually, I think, often, not front and center. The relationship that at least in family medicine, that is flagged is the kind of healthcare professional patient, but also family, right? There's that expansion. But here, I'm also flagging the relevance of the caregivers of people with IDD and how important those relationships are for everything.
Thank you. Do we have any other questions before we wrap up? Okay. And I guess we can end a little bit early today.
I think Gina has a question.
Oh, my apologies. Go ahead.
Oh, apologies. It wasn't so much a question as it is a comment to dovetail off of Dr. Sullivan's comments around the caregivers of the family members. And as Angie so generously mentioned, I'm one of the geriatric psychiatrists that supports the Plus 45 clinic. And, time and time again, I'm struck by the grief that the family members go through as their family member with an intellectual disability or a developmental delay gets, their brain changes, they age into these themes of geriatrics, they become more frail, and how much potential there is for us, especially in the space of geriatric psychiatry, to support them in their grief. And that's one of the themes that I want to explore as I go on in my work in this clinic. And also, we had talked a little bit about a capacity and the system and public health policy. One of the goals in moving forward in my work in the Plus 45 clinic is also to have more trainees and learners to come into the clinic and to work with me. So, for example, we will have a geriatrician from Ireland come and work with us and spend some time with us, just for them to see this multidisciplinary model of care, involving the direct support professional, the family members, the behavioral therapist, the social worker, the family physician, and also to discuss the role of the caregiver in their grief process as well. So those were just some comments, and thank you so much again for this really, really insightful topic that is very near and dear to my heart and to yours as well, Dr. Sullivan. Thank you again, and Angie, and looking forward to working together.
Oh, great. Well, I really appreciate those comments. One of the things that I think this approach also helps to guard against, that I think your comments raised, is, in the context of fear and grief, that affects deciding. And sometimes the negative effect is to overdo it. And for example, end-of-life care in New York, for instance, a colleague has said that it is very difficult for, say, somebody with at the end of life with Down syndrome not to end up dying in the intensive care unit. And why is that happening? So part of the analysis is it's not just the logic, it has to do with the affect, and it has to do with how fear can drive decisions that may be excessive. So this over treatment that can happen. So I think that that's also helpful to think about goals as a way of sort of rethinking about what are the goals, like what's the good, and ultimately what's the good, right? It could be that grief has a spiritual component as well that is relevant to deciding. And one other comment I would make from pediatrics is it's very well known that or a common theme is the importance of attachment and how important that is to development. And also the negative side of that, how long-lasting adverse childhood events can be for somebody's whole life, such early trauma, etc. And again, just flagging the relevance of relationships and the quality of those relationships. One of the interventions that the H-Card program has done is to bring together caregivers of adults with intellectual disabilities and help them to accept, kind of accepting the grief and struggles that they are experiencing and how important that is to everybody's flourishing. So the other thing about a relational approach is that you're not atomizing a community, that they are actually, if you're caring for one, you're caring for the others as well. And that they all flourish together. And just to kind of, often, there's these big international debates about, Indy Gregory, and there's this atomizing of the person as if they're not to be understood as embedded in relationships. And our care is to the community, not only to the individual. So thanks for raising those issues.
Great message. Thank you. And thank you again to you both for your wonderful presentation and this, this discussion afterwards. I think it's very beneficial for everyone. A reminder that we will be sending the